Hello. Today we're going to be discussing bronchiolitis and bronchiolitis scoring in the pediatric setting. Our objectives for this presentation is to understand what bronchiolitis is. What are some of the risk factors of bronchiolitis? What is the clinical presentation of a child exhibiting bronchiolitis? We'll also go over the scoring tool that we'll use to determine the treatment and of course go over those treatment options as well. Bronchiolitis is inflammation of the bronchioles, usually caused by an acute viral illness such as respiratory syncytial virus or RSV. It is the most common lower respiratory tract infection in children younger than 2 years of age. We can see a representation of this in the picture on the screen. On the left, we see healthy bronchioles with thin walls and large airway openings. On the right, we have airways with bronchiolitis. We can see the airway walls have increased inflammation as well as increased mucus production, all of which is reducing the size of the airway, allowing less air to travel. Bronchiolitis has become one of the most common reasons for hospitalization in children younger than 2 years of age during the winter months. Initial presentation includes a runny nose, nasal congestion, decreased appetite, and cough, usually for approximately 3 days. Respiratory distress impedes appropriate oral intake, resulting in frequent clinician visits and admission to the hospital. Children at higher risk for severe disease include less than 12 weeks of age at time of infection, those born before 29 weeks of age, and those with underlying chronic pulmonary, neurologic, or hemodynamically significant cardiac disease. Bronchiolitis is mainly a clinical diagnosis. The diagnosis and severity of the illness should be made after eliciting a good history of present illness and based on the clinical manifestation of the patient. Children with bronchiolitis initially develop signs and symptoms consistent with upper respiratory infection, including rhinorrhea, nasal congestion, cough, and fever. Parents may also note decreased oral intake, general malaise, increased fussiness, and poor sleep secondary to nasal congestion. The disease progresses to include signs of lower respiratory tract involvement, including increased work of breathing, worsening cough, and wheezes. In addition to seeking details of these historical points, when seeing a child with possible bronchiolitis, you should ask about oral fluid intake and urine output, as dehydration is common. Also make sure to ask about periods of cyanosis or apnea, as premature infants and infants less than 2 months old are at higher risk for apnea. When examining a baby with suspected bronchiolitis, first start with a review of the vital signs and an assessment of her general appearance. Is the baby febrile, tachypnic, tachycardic, or hypoxemic? Does the baby appear interactive and playful, or is she lethargic or irritable? Assess for hydration status by checking the fullness of the anterior fontanelle, presence of tears with crying, mucous membranes, and capillary refill. Carefully observe for signs of increased work of breathing. Retraction can be supraclavicular, intercostal, or subcostal. If present, note whether these are mild, moderate, or severe. Nasal flaring or grunting can be seen with more significant respiratory distress. Although you have yet to auscultate her lungs, you have already gathered some of the most important information that you'll need about her clinical status just by observation. The classic description of the lung exam of a baby with bronchiolitis is sounding like a washerboard with coarse crackles heard on inspiration and expiration. Babies will frequently have associated wheezes with a higher pitched and polyphonic. Note whether there are specific areas where breath sounds are diminished compared to other areas. Because areas of mucus plugging can shift with cough, the areas of decreased aeration may shift over time. Prolonged expiratory phase is also common. The diagnosis of bronchiolitis is a clinical one. typically chest x-rays and labs, including specific respiratory viral testings, are not necessary to make the diagnosis, nor are they recommended in the current guidelines from the American Academy of Pediatrics. Targeted testing in selected patients, for example, those with pre-existing medical conditions, may be helpful to exclude alternative diagnoses. Viral testing may be helpful to cohort patients or in discontinuation of anti-influenza treatments. Unusual features in history such as poor growth, recurrent or severe symptoms, or clinical course that does not follow the anticipated pattern should prompt consideration of alternate diagnoses. Bacterial pneumonia is a frequent consideration, particularly when auscultation reveals a consistent area of decreased aeration or when there is a high or persistent fever. Chest x-ray may be helpful in this situation, but caution must be taken to avoid overinterpretation of atelectasis as an infiltrate. Recurrent viral-induced wheezes or reactive airway disease can be difficult to distinguish from bronchiolitis. Additional consideration may include oropharyngeal dysphagia, leading to pulmonary aspiration, foreign body aspiration, chronic pulmonary disease such as cystic fibrosis or cardiac disease such as heart failure. Numerous scoring instruments are available for assessing the severity of bronchiolitis that provide a uniform method of serially assessing illness severity. Severity scores generally consist of a combination of vital signs and clinical findings. Variables that are commonly included are respiratory rate, degree of retractions and accessory muscle use, lung examination, which includes aeration and degree of wheezing, and level of alertness, activity, and feeding. Infants with mild bronchiolitis have little to no respiratory distress and normal mental status and activity level. Infants with moderately severe bronchiolitis are usually tachypnic with moderately increased work of breathing, i.e., mild to moderate retractions without grunting or head bobbing, no apnea, and normal level alertness. Infants with severe bronchiolitis have persistent tachypnea and considerable respiratory distress. Example, retractions, grunting, nasal flaring, and head bobbing. Other findings that indicate severe illness include agitation, apnea, and/or poor responsiveness. Apnea occurs most commonly in preterm infants and those less than 2 months of age. Commonly used tools include the respiratory severity score or the pediatric bronchiolitis scoring tool. At Peace Health Southwest, we use the pediatric bronchiolitis scoring tool. While these severity assessment tools have been adopted into routine clinical practice in many centers, it should be noted that they all have limitations. They are somewhat subjective and they sometimes do not capture the full clinical pictures. This is why many institutions have initial and recurring assessments performed with 2 caregivers to get the most accurate representation of the patient's bronchiolitis score, as is the practice at Peace Health. Scoring should also be done before and after suctioning. The pediatric bronchiolitis scoring tool allows the caregiver to determine what pathways should be taken regarding cares and frequency in an effort to minimize the need for escalation of cares. Supportive cares and anticipatory guidance are the mainstays of management of mild bronchiolitis. Patients with persistent hypoxemia should receive supplemental oxygen as needed. Those with severe distress may require high-flow nasal cannula. Supportive care also includes maintenance of adequate hydration, relief of nasal congestion or obstruction, and monitoring for disease progression. When providing nasal suctioning, care must be taken to avoid nasal trauma that can result in more swelling. Infants and children with mild bronchiolitis who are treated in the outpatient settings generally do not require any specific pharmacologic interventions, for example, bronchodilators or glucocorticoids, since mildly affected patients generally recover well with supportive care alone. Bronchodilator therapy generally does not play a significant role in the management of bronchiolitis, particularly in patients without severe symptoms or wheezing, and it is not recommended by the AAP. Bronchiolitis is a self-limiting illness and will resolve in most children without complications within a few days. Most infants and children who have received treatment for bronchiolitis in the emergency department or inpatient setting can be monitored at home with follow-ups as needed. At, at a minimum, the following criteria should be met for discharge from the hospital or emergency department. Patient's tachypnea and work of breathing have resolved or improved. A pediatric bronchiolitis scoring tool score of mild on 2 consecutive assessments. Hypoxemia resolved for at least 12 hours and no apnea for at least 24 hours if admitted to a medical unit. The patient should have adequate oral intake to prevent dehydration. They should also have resources at home to adequately support the use of any necessary home therapy. For example, maybe bronchodilators if there was a trial that was successful and this therapy is to be continued at home. Caregivers should also be confident they can provide care at home, including clear use of nasal suctioning to clear the infant's airways if necessary. This concludes the education on pediatric bronchiolitis and bronchiolitis scoring. I hope it was as informative to you as it was to me. Please continue with your education and additional resources by viewing the pediatric bronchiolitis scoring case studies. Thank you and have a nice day.